And this is the worst thing that I've ever done. I don't remember. I'm so sorry. Most embarrassing moment of my life. Just ruined my chances at that program.
I have something to share. And she said, sure. And so at the end of our Zoom session, that was my first disclosure, saying that what we were learning in class, I had experienced it myself. And the amount of emotional support that I received from those 20 medical students was overwhelming.
Just finished my talk on lived experience in psychiatry, and it went phenomenally. So many people shared their own stories, disclosed for the first time. I recorded the presentation and panel talk, so we'll be publishing it on the podcast, like as a patient doctor, and on my YouTube channel after the conference, and I'll be removing the people who share their individual stories. I'll be giving a gist of what we responded to, but wanted to share at APA. When I first became a resident at Rosalind Franklin, this was the workbook that they handed all the patients. They would just hand the patients this, and patients were like, okay, and then they would throw it away. They would never see it again. It has kind of the rules of the unit, and then just tons of DBT, but it's not organized. And it's tiny words, and we do have vets that have smaller, that need smaller vision. So what we did is, when I was a fourth year medical student, I did group therapy as part of my child and adolescence. I did a lot of group therapy for teens, and we created a kind of like a Google Docs presentation. And so we took that Google presentation, took this with my medical student research group that I created with medical students and residents. We created this. We built my group therapy from teens, took all the DBT, added CBT, cognitive behavioral therapy, added somatic therapy. So every single session is a mindfulness at the beginning and end. We added art component for different learners. We increased the size for our vets so they can read, and actually organized it into a session. And every single session that I would run on these units, because we have native spooks that are waiting to be separated from the military because they couldn't handle it. So then I go through a group therapy session with them. To start with a mindfulness activity, we do a teaching activity where I have them each go around and read a section, because at first I was just doing it that I was reading to them, and then of course we have 13 teenagers. So now what I do is I say, we're popcorning. I'm just here as an observer. I did that to have the Dr. Yalam's group therapy book. I read through all of his group therapy curriculum, and that's part of his training for group therapists, is to allow them to learn how to interact with others. So they then learn, and then we get to the points that are an active activity. So one activity is doing the ACEs, the Adverse Childhood Experiences. Another thing is doing, this is a DBT, dialectical behavioral therapy. This is a front and back. So this is my personal favorite session is the one on trauma.
They're just writing like such, for example,
where we go through how does trauma interact, come out in the body. And then they do a front and battle mask. That's what this is, where how they present themselves to the world on the front. And this is very dialectical behavioral therapy, what they do for PTSD. The reason I do it is because the majority of my recruits I found had a significant amount of ACEs, adverse childhood experiences. In the poster I'm going to do tomorrow, you'll see how many. Six adverse childhood experiences was the average of my inpatient meeting retreats that were on the unit. Now that I'm about to be a third year resident, now I do this outpatient. Now, if I have a patient that comes in with sleep problems, I just turn to my insomnia, I rip it out, and then we go over in the session to do. So that's how I then have transitioned our workbook into inpatient setting to now how I continue to use it now. So, thank you. Thank you.
I have something to share. And she said, sure. And so at the end of our Zoom session, that was my first disclosure, saying that what we were learning in class, I had experienced it myself. And the amount of emotional support that I received from those 20 medical students was overwhelming. And that was when I was like, oh, it's okay to share that I struggle. Even though in medical school, we all like to pretend we're perfect. We all like to pretend we know everything. But just having that vulnerability was huge. And that's where I ended up getting in contact with my new medical school best friend, who shared also a lived experience of trauma. Fast forward to still in MS2, step 1. I struggle, of course. Failure of courses led me to push step 1 studying, pushed me into a leave of absence, pushed me into having financial struggle because you don't get loans if you're in a leave of absence. So almost lost our housing and rent while in leave of absence. We were going off of my husband's medical student loans, which already wasn't enough for one person. So significant struggles financially. And I kept failing the step 1. I failed it once. The first time I failed it, I took that personally. I felt that failure word, I took it as myself, I'm a failure, and went into this deep, even more depression, where I then started to reconsider being alive. And then my friend reached out, that one that I said that had trauma. And she was like, have you heard of accommodations? Why don't you apply for accommodations? Accommodations for what? I don't have a disability. So I had internalized this, what it meant to be a disability or be disabled. And I didn't identify with that. At that point, I started to realize, what if I do ask for help? Help. So I applied for accommodations. I received only at that time extra break time. I ended up failing again, this time with accommodations, but again, when I meet with medical students, I always talk to them who have failed and are in a leave of absence. I tell them, let's look at the hierarchy of needs. If your basic needs are not met, food, housing, support, then how in the world are you supposed to do the self-actualization of medical school, becoming a doctor? So that's how I failed step 1 a second time. But once I got my needs met, then I finally passed step 1. Okay, let's move finally to MS3. This is where we talk about the blowback, because this is where I started getting in trouble with the institution, to my medical school institution, because I was vocal. I had just spent a year during my leave of absence sharing my struggles, sharing that I had failure, I had struggles. I had become vocal. I started going on social media and sharing. I started writing op-eds about this experience, because I started learning I'm not alone with failure. I'm not alone with these experiences. So that's where I started receiving the true blowback. Start crying in front of a resident, led me for professionalism, asking for accommodations to see my therapist, another professionalism. I almost got kicked out of medical school. I could spend an entire talk on just how to deal with discrimination and that. I'm not gonna go there right now, but I kept going because I knew there were other people that were dealing with this and that I wasn't alone. Okay, so fast forward to 4th year at medical school. Now I have to decide, okay, I'm applying to residency. I ended up dual applying to increase my chances, family medicine, psychiatry, because I knew I had a red flag, failure, mental illness, struggle. I ended up deciding to put my lived experience in my personal statement, in my ERAS application. but learning how to disclose it in a way that shared my story, didn't just throw it out, oh, I have this specific disability. No, just explaining, I have an experience that changed the way I look at myself and I look at how I help patients. I was giving a talk during my M4 year on whether or not to disclose during your residency interviews. And at the end of that talk, I realized, why am I'm being a doctor of telling other people to do it when I'm not doing it myself. I looked back and I was like, I haven't actually disclosed in my interviews yet. So then the next day was my interview at my current institution, and my program director. And I ended up deciding, okay, I feel safe at this point. I feel safety in the numbers that enough people want me in these interviews. I've had enough that I think I'm ready. And that was when I disclosed to the program director. And the amount of, again, support was impressive. Oh yeah, that's not a big deal. We've helped people all the time. Yeah, we can work around, okay, what do you need? Less patient numbers, less time, like days off. Amazing. So in total, and that's how then when I got into residency, I ended up matching at this institution. And my advocacy continued. In fourth year is when I started my podcast, where I started, since in leave of absence, when I started journaling and writing about the struggles. So I was like, okay, people aren't reading my blogs. Let's turn it into audio, which then I realized, oh, people aren't listening to podcasts. They want a video. Okay, then I'll do a video then. So now I'm on YouTube. But hey, that's what got it to be people to pay attention and to share. And since, I think it's now been about a year on YouTube, 3 years since I started the podcast and writing, maybe 4 years if you want to go since op-eds and writing. And the amount of people that contact me, medical students, DOs, MDs, Caribbeans, IMGs, all across, residents who are struggling similarly, that have failed and feel like failures, who are in a leave of absence or gap years because their school wasn't able to support them with whatever their mental or physical health needs. Their struggle to receive accommodations in their complex exam or their accommodations. People that are being kicked out of medical school and residency for having lived experience because they can't, because of whatever word institutionally they want to throw at them, professionalism. So I'm so thankful to be a part of this panel, and hopefully you can sign the petition to make this an actual caucus, because we all have some sort of lived experience, because we're all human. Thank you.
Hello, I just came out of a phenomenal presentation. There were 3 presentations that were phenomenal. This morning I went to a breakfast for residents, which I didn't even know what it would be about. I just was like, free breakfast? Yes. It ended up being a talk by Johnson & Johnson, and I was like, oh, what did I get myself into? But the talk was actually about that bias right there of, in medical education, we become so fearful of anything to do with pharma. And we learned through this talk, which I actually was really excited because I met the APA president there. I met a new future mentor, but we talked about something called a medical affairs representative versus a sales rep. So the difference between the two, so a medical affairs rep, they're the ones who can provide all their publications on the medications and all the like if you have a question about the medication, about the side effects, they actually have the studies, and they will one-to-one talk to you to get feedback to bring back to the people that are making these medications and figuring out if they need to do more studies or research into it. So very different than the sales reps who kind of, we in medicine kind of say fear or the big bad pharma that are just trying to sell meds. 2 different groups of individuals in a whole system. So that was really fascinating. And then I went over to the actual conference. I went first to an AI talk, which was really unique. I've been going to every single AI talk in mental health at ACCAP and now at APA. So I'll be taking in all those notes but I guess the summary overview, quick, that I can remember from the AI talk was that the positive of AI mental health apps have been shown to be as helpful as mindfulness apps, like just the support it can provide. But it has more harms for mental health than positives at this time. And some things that they're doing research to improve it is like having a TSA when you go to the airport to check if what the person has written initially is something concerning, and then like a TSA after you leave the airport to say, okay, did the information that the bot provided was actually helpful or was it harmful? And then another big thing that they saw is people using AI over time and forming relationships. That's really where the significant amount of harm comes when people are making long-term relationships with these AI bots. That's where the psychosis, delusions, people getting all their investment into these instead of looking at other perspectives. I have a great AI video that I created about specific delusions, but I will definitely, after going to all these talks on AI, I will make a better video explaining this now that I feel like I've started to get a little bit more of an understanding. Of course, I'm not even close to understanding it fully, but just a step further. Okay, that was the amazing AI talk. And then I then went to a session on biases, and this was huge regarding biases in how we analyze patients, what the purpose is, and we even talked about the hidden curriculum of why attendings that fight back against your diagnosis is actually beneficial, because it makes you rethink of the opposite. Even if you are correct, by having the attending, having you consider the opposite, that is the most important way that forensic psychiatrists recommend, and they do, to make sure that they are 100% correct with the final decision. That was a lot more information's coming there, and I'll be able to digest it and share it, but I wanted to share a little bit of those 3 amazing experiences for the morning. I'm gonna go to downstairs where the food is and the different events, and my poster session on the suicide risk factor, which I met yesterday a group of residents who are in charge of the Marine FHCC. So I always say we're the most unique, and yes, we're the most unique for Navy, but I met 2 residents that are part of the Marines. So that is huge, and I can't wait to share more about them and collaborate with them so we can share what we've learned working with Navy recruits, and they can share what they've learned working with Marine recruits with suicidality. So I'm very excited, but let's go more downstairs to see what the rest of the conference is about. I am done for the morning. I just, to reset, had a massage and vibration, really working on resetting before I present at my poster for the last poster. This is my last day at the conference. Oh, we're going to go by the art exhibit, because I think the art exhibit is phenomenal what people have been doing on. I will switch the camera and then we can see this. It's what empowers your practice. And I'll also take a picture of it. I'm gonna go get my poster because I forgot it, because I got up super early I'm 2 hours ahead, so it's not super early. It was super early for people here. Got up at 6 a.m. here, which was 8 a.m. in Chicago. Right now, I'll be going back to my hotel, picking up my poster for the poster session, which is over there. So I'll be going getting my poster. I'm also going to get free lunch at the Hispanic Psychiatry Caucus and then present my poster. And then later on, I'm going to the Child and Adolescent Dinner Caucus. But yes, wonderful day. I said I was going to do this and I keep forgetting, so I'm going to do it right now while I walk to the hotel. The things that you need to bring when you're going to a conference is one, tennis shoes. I learned that probably on my very first conference during medical school. Yes, I love shoes, but very comfortable tennis shoes. Think about you're going to surgery, you're walking. If you're going to surgery, you want comfortable walking shoes. Same thing. You can always change your shoes for your presentations or poster presentations. Also, layers, especially if they're in different parts of the country where it randomly gets hot or cold or AC on, and then a water bottle, which, as I say it, my water bottle is back in the hotel because I thought I would get home earlier. So that's my tidbits. And I see that population that come to my emergency room. But the biggest thing I see is these Navy recruits. Why is that? Because they start boot camp in the first, I don't know if any of you are in the military, but have done boot camp, but the first 48 hours they're forced to stay awake. Why they do that? They have learned that we know from science can self-induce manic episode or a psychotic episode. Rather than have that here in a safe environment versus on a Navy ship. So the second that something like that happens, they send to our emergency room where our psych residents get to see them and evaluate them to determine admit into our psychiatric ward or discharge back to base. So that is our first kind of background to understand where I'm at in the emergency room. And the reason it's important is those psychotic and manic patients, those are the patients we want for our medical education to learn from. What is the reality? Is we just get a lot of patients who are just adjustment disorder suicidality, that they are told on the base, you don't like boot camp, such to such, you are trapped, you signed a contract. What does that happen for someone in trauma? You feel stuck, they become suicidal. I literally have this conversation with my recruits every day, is they told me you cannot leave the military. That is wrong and not true. You can leave. That's why you're here. Go right back. But now I have to determine who's suicidal, that I actually have to worry about attempting suicide. And it happens all the time that we have recruits that commit suicide on the base, and we see them also in the emergency room. So this is our challenge of how do I differentiate these two type of populations? Someone who needs to be on the inpatient psychiatric ward, or that I can just give them you can do it talk back to base, you do it and you can separate. That was as a first year resident, I struggled a lot making that differentiation of who's actually meaningful to be admitted versus discharged. We have no guidelines besides just what's out there. Every single recruit that comes in by the VA policy gets just screened. Are you suicidal? That's literally their first. If you're a recruit, the first word that comes out of the triage is not why you're here. Are you suicidal? Yes, no. If the answer is yes, psych consult, and I'm the only psych doctor that shows up. So that's problem number one, figuring out. Also, I have tons of recruits. We have weeks that just so many recruits coming in. 8 to 10 are just filling up emergency rooms waiting for my full psychiatric evaluation. I created this form that you can pull up here. You can pull up my form here. On one side is the adverse childhood experiences. On the other side is the statement I will be asking to gauge what is your risk factor for suicide. I took some of these questions from the comprehensive that I already had to fill out for these patients, and this will also bring in what is the VA if you haven't been in the VA. And then we also looked at research of what is actually the highest risk factors for suicidality, family history, personal history, things like that. So that's what I would end up doing. I'd walk around the emergency room, handing out a form to all these recruits in the emergency room, say, fill this out front and back, I'll see you later. Fill this out front and back, I'll see you later. And while I'm doing this, I'm also seeing how they react. And that also helped me, gave me some idea of, for one, are they catatonic? some that would just stare at it and not know what to do. I'm like, oh, I need to spend more time with or, and I was so surprised that even psychotic admitted people were filling it out. So they did a great job. But anyway, I like to talk a lot to explain the background. That's why I created this form. I'm going to pass it off to my medical student who is not at my school. So she had a complete unbiased experience to look at the data, see, okay, these forms I created and I wrote down admit or discharge. What was the actual statistic significance of using these forms? Was it actually, I know for me it was helpful. It cut down my time, 45 minute interviews to 10 minutes. Or was it that statistically way?
So I tell one of those two types of factors, you can get assigned that as 1 point. And I took the back side as well that had the ACEs and assigned 1 point in patients that had 4 or more ACEs and 0 points to those who had 3 or less, and then calculated the mean flat and validated those who were admitted had a mean risk score of 7.2, but those who were discharged. From there, I created a RC curve to assess how effective the tool was at reaching those who would be admitted versus those who would be discharged. And it found that 72% of the time, those who were admitted had higher risk score of discharge. I also found that the mean ACE score, so those who were admitted, was 5.3 versus just 1.3 for those who were discharged, which I think is part of the tool to differentiate those who should be admitted than those who would be discharged. I also calculated the odds ratio, found that each yes on the form was associated with a 36% increase in odds.
So I just went to ACCAP, meeting all the so important people. It was phenomenal because I got to see a lot of fellows. My eyeliner already, it's already been a long day. Last day in APA, American Psychiatric Association in San Francisco. And then I finished off the night at this steakhouse. Did not have steak though. They only had alcohol and small little drinks and some water. That leads to one of the most embarrassing moments of my life, of my education. So, ready for this. Okay, so like what I tell medical students, you guys are applying to residency and networking is so important. Now I'm applying to fellowship. Networking is so important. So here I am in my networking hat. One of my previous chiefs tells me, hey, you need to go talk to that person. It is an APD. So in one of the hospitals that I want to go to and apply to. Perfect. So I go and meet this APD. I make an amazing impression, and I honestly wasn't even fully considering that program. Now I'm 100%. And okay, so that happens. Amazing talk. Okay, hour later, I meet with someone else, super important. And they're like, hey, have you met, let's call him Bob. We met Bob. He's the president of fellowship. And so here my brain is thinking, oh, he is a fellow, and meet with Bob. And he looks at me. He's like, Stephanie, we just met an hour ago. And this is the worst thing that I've ever done. Like, I don't remember. I'm so sorry. Most embarrassing moment of my life. I just ruined my chances at that program. Okay, and then I go to the bar to put my wine away and change it, because obviously my 3 sips of wine have made me forget in the hour that I met a very important person. So I meet one of the people on that knew me from YouTube. We took a picture together, told me that both supported me. I have had so many people in APA that have done this, that have come up to me. And so thank you if you came up and said hi to me and shared your story. You are the reason I do what I do, where I share my own struggles to inspire you so you don't have to do my struggles. So I am so glad that I've made so much of a meaningful impact. That means so much to me. So anyway, thank you, this medical student that dealt with me at the bar, asking for water and sparkling water and pineapple, because obviously 3 sips of wine was too much. And he bolstered me up and he said, you could apologize and make it as a funny. I'm like, you know what? You're so right. It's going to be so much better if I go and apologize and just be honest. I think he said honesty is the best policy. And I'm like, yes, you're totally % right. And so I did it.
I went back up to the guy. He kept moving away from me like he didn't want to talk to me because he knew I forgot. And I'm like, oh my God, I made this so much worse. Okay. And then I grabbed him and I'm like, I want to say I apologize so much. I had known you as the APD doctor, and then someone else connected with me that you were the fellow president, and I thought you were a fellow, and I am so sorry. My brain, I could not. I'm so sorry. And he thought it was funny and fine and we're great. And I still think that you know what, I made a connection, and I made a remember me. And then I also showed off my workbook, and this person that was also very important in Chicago loved it. But now, thanks to San Francisco, let's head home to Chicago. Take care.